and welcome to ASC's webinar series. I am Liz Lane, ASC's Online Education Manager. Today's webinar is titled Use of TEE to Assist with Surgical Decision-Making in the Operating Room, a Surgery-Based Approach. Before we get started, I have a few housekeeping items that I would like to go over with you. Since this is a live webinar, you have the opportunity to have your questions answered by the panelists. To ask a question, use the Q&A tab at the bottom of your screen. Feel free to ask a question at any point during the presentation. However, keep in mind that questions will be answered at the end of the presentation. We will do our best to ensure that all questions are answered. However, this may not be possible depending upon the number of questions presented. A Q&A handout will be made available when the enduring webinar is posted. Instructions on how to claim CME credit for attending today's webinar will be emailed to you after the webinar concludes. And finally, if you experience any technical problems during the course of this webinar, please submit a message using the Q&A feature. We will have a technical expert there to help out with whatever problems you may have. Let me introduce today's speakers. Dr. Alina Nicoara is a cardiac anesthesiologist and currently serves as a Director of Perioperative Echocardiography at Duke University. She also serves as the chair of the ASC Council on Perioperative Echocardiography Steering Committee. Our second speaker today is Dr. Nikolaos Skubas. He is a professor and chairman for the Department of Cardiothoracic Anesthesiology at Cleveland Clinic, located in Cleveland, Ohio. He also serves as an executive section editor at Anesthesia and Analgesia, specializing in cardiovascular anesthesiology and perioperative TEE. Welcome, Dr. Nicoara and Dr. Skubas.
Thank you so much. It is a pleasure hosting this webinar today together with Dr. Nick Skubas and Ms. Liz Lane, and I am very glad that you have joined us. What we will try to do over the next 45 minutes or so is go over the recent document that has been, the recent document that has been published in the June issue of the Journal of the American Society of Echocardiography, and it addresses the use of intraoperative transesophageal echocardiography to assist in surgical decision-making. I would also like to thank the American Society of Echocardiography for hosting this webinar. This was our writing group. This document has been written in collaboration with the Society of Cardiovascular Anesthesiologists and Society of Thoracic Surgeons. And as you can see, we have representatives from both societies on the writing group. Also, we would like to thank all the reviewers from the American Society of Echocardiography, the Society of Cardiovascular Anesthesiologists, and the Society of Thoracic Surgeons. And also, and especially, we would like to thank Dr. Alan Perlman, who is Emeritus Editor of JACE, for his gracious review of the document, and also Dr. Mike Picard, who is the Editor-in-Chief of JACE. So what is the purpose, what was the rationale behind this document? Transesophageal echocardiography has grown and matured as a sophisticated imaging tool at the same time with numerous developments in cardiac surgery. Cardiac surgery is now minimally invasive or hybrid. There has been an explosion of mechanical circulatory support, and we are taking care of more and more complex patients. All these changes have led to the increased integration of TEE in the care of the cardiac surgery patient, be it for optimization of pre-surgical planning, hemodynamic management, or post-surgical assessment. So the purpose of this document is not to rewrite existing guidelines, but rather to help integrate these existing guidelines into a roadmap for imaging and interrogation of cardiac structure and function specific to the challenges of the intraoperative environment for some of the more common surgical procedures. So the document addresses different types of valve surgery, coronary artery bypass graft surgery, aortic surgery, mechanical circulatory support, both durable and temporary, and transplant surgery, hypertrophic cardiomyopathy, and pericardial diseases. What the document doesn't cover is, for example, indications and contraindications to intraoperative TEE. This has been addressed in several review papers, as well as in the guidelines for performing a comprehensive TEE exam led by Dr. Rebecca Hahn in 2013. Doesn't address training requirements. These have been addressed in other guideline documents, more recently in the 2019 statement, ACC, ASE, and AHA, led by Dr. Susan Wiggers, and also doesn't address the issues of equipment, storing of a TEE exam, reporting of a TEE exam. These have been addressed in other guideline documents, such as the ASE guidelines for quality echo lab operation from 2011, led by Dr. Picard, or the continuous quality improvement for perioperative echocardiography, led by Dr. Matthew in 2006. It also doesn't present a roadmap for procedures such as adult cardiac congenital and transcatheter procedures. These are very diverse procedures, highly specialized, and they should and will have guideline documents of their own. So as an outline of the webinar, what we hope to cover is talk a little bit about how the intraoperative environment is different. What is the added value of intraoperative TEE in surgical decision-making? Present a proposed systematic approach, a roadmap to identification of intraoperative TEE elements which are important in surgical decision-making, and ultimately highlight some things regarding the heart team in the operating room, such as the importance of communication and emphasis on the team approach. So we'll start with the intraoperative environment.
Okay. Thank you, Alina, and good afternoon to everybody who has joined us in this webinar. The next slides present the differences in the place where the TEE is happening. We are addressing the intraoperative transesophageal echocardiography, and for those who do not practice in the operating room, there is a difference between the lab, the protected space by the patient's bedside, and the operating room. First and foremost, the patient is anesthetized, and as the exam takes place and interpretation of the images is being formed, everybody should keep in mind, whether anesthesiologist or not, that you are observing the changes in structure and imaging caused by anesthetics. So anesthetics cause vasodilatation, affect the afterload. So things may not be, for example, as you can see later on, mitral regurgitation may not be the same in an awake versus an anesthetized patient. So hemodynamics change, and sometimes do change in a very dynamic fashion, because while the exam is underway, you may have interference from the surgeon with electrocautery, manipulation of cardiac structures in the body of the patient from outside. It is not a quiet place. It is not similar to the lab, where there's only the operator, the assistant, and the patient. The patient is asleep, but there are teams of people working around. The light is very bright, there may be noise, and the physical space actually may be very limited. So easily somebody may get distracted while trying to go down the path of a comprehensive TEE exam. Another crucial difference between the intraoperative environment and the lab is the lab will, in the lab, usually the TE will go down a structured path and somebody will report offline. This is not the same in the operating room. Communication with the team happens throughout the case in real time, and things are passed across the ether screen continuously. So what you see, you communicate with your surgical colleague, and he or she will communicate back to you things that they see on the field, and you try to correlate and detect on the echo as well at the same time. So the place is busy, the environment is very busy, can be distracting. At the same time, the exam is not always well structured and comprehensive, but maybe going back and forth from A to Z and backwards, trying to be focusing at different times on different structures, depending upon what the question may be from the other side, from the surgeon, or what else may be going at the same time in the operating room and on the patient. So the highlighted difference between operating room and the lab is that the exam is repetitive and at times focused, but always as comprehensive as possible. So the next big item that we try to address in these guidelines is why one will bother to perform intraoperative TEE. It's very easy to believe in that from those who do it at all times, but for those who have questions, what is the added benefit of performing TEE before bypass? First and foremost, the patients do have a previous diagnosis, and most of the times we're dealing with elective cases. It is the purpose of the pre-bypass exam is to confirm the diagnosis and make sure that nothing else has been added or has been missed or has changed since the case was booked. So for example, particularly in mitral valve surgery or aortic valve repair surgery, TEE sometimes will be much more detailed in providing anatomic information regarding mitral valve repair, cusps, motion. The same more so for aortic valve if aortic insufficiency or the morphology is such that the aortic valve may be amenable to repair. So refining the findings is important to happen in the pre-bypass period. And since we talked about anesthetics changing the hemodynamic environment, any new findings should be examined under the effect of the anesthetic, but at the same time we always think of how our plan as anesthesiologists may have to be changed based upon the findings that may also have to amend the surgical plan after communicating findings with the surgeon. And for those cases that happen to come without a complete workup, such as in urgent and emergency cases, obviously the TEE may be the first echo workup ever possible for these patients. So there, the role and the significance of the findings are even much more important. And some diseases that we may see more often, and with evolving very fast between the time of diagnosis and the time of operation, such as infective endocarditis, or patients who had big MIs, obviously complications, shunts, VSDs, or disappearance of masses or appearance of new masses in other valves. It's very important to document or look for in the pre-bypass period with TEE.
And to demonstrate this last point, this is a case I actually did a couple of years ago. It was a 66-year-old male who presented with an NSTEMI. He had a history of chronic atrial fibrillation, and these are loops, selected loops from his preoperative workup TTE, and you can see that there is definitely MR, it's present, it's moderate to severe. However, 2 days later, when he presented to the operating room, his MR has significantly worsened. And you can appreciate here that there is prolapse in the posterior mitral valve leaflet and what seems to be an incomplete rupture of the papillary muscle. So this patient underwent a coronary artery bypass graft and replacement of his mitral valve. Pre-bypass intraoperative TEE is also useful in minimally invasive procedures. We can now perform a cardiopulmonary bypass through a port access with a closed chest. In this particular case, surgeons cannot see or directly feel the cardiac structures. Adequate placement of the guide wires and the cannulation is not performed under direct visualization by the surgeon. So guidance of this placement is crucial. Post-bypass, TEE can monitor for cardiopulmonary bypass complications such as presence of left ventricular distension if there is significant aortic regurgitation present, unfortunate presence of aortic dissection, and can also monitor the presence of various catheters and cannulas that have placed for the conduct of the cardiopulmonary bypass. So is the left ventricular vent truly going through the mitral valve leaflets? Is the coronary sinus retrograde cardioplegia catheter in the right place? You can actually monitor the delivery of the cardioplegia solution. And specifically in port access surgery, it's crucial to monitor the position of the aortic endoclamp, as this can migrate either towards the aortic valve or towards the aortic arch and occlude the great vessels. Post-bypass TEE is particularly useful for interrogation for intracardiac air, which may accumulate in anterior structures such as left ventricular apex, left atrial appendage, and undesirably so, sometimes up the right coronary artery, which may lead to transient RV dysfunction. So it's particularly useful to use TEE for monitoring of efficiency of the airing maneuvers and monitoring for the timing for removal of the aortic root vent. But our most important role post-bypass is obviously in assessing surgical results and ruling out possible complications associated with the surgical procedure. And we cannot emphasize enough how important it is to actually discuss and know the surgical procedure that has been performed in order to be able to assess the results. This assessment is time sensitive, and the decision to re-repair or replace that mitral valve or to address that paravalvular leak has to be done, as Nick has stated before, in real time, and has to be done fast. We may be caring for the patient at the same time we are performing this TEE examination in quite less than ideal conditions sometimes. There is prosthetic material, there may be sutures, air, lap pads, chest tubes, which could degrade the quality of imaging. At the same time, the surgeon is still performing a surgical procedure, and they are receiving a great deal of information which has to be reconciled with the hemodynamic data, patient factors, and expected challenges, be it immediate technical if we do have to go back on pump, or down the road in patient recovery. So it can be quite a stressful time. However, there is no better time to be a team than right then. We can also, and we should also, assess post-bypass for complications related to cardiopulmonary bypass. And as Nick has stated before, the exam starts as being focused, looking at surgical results and possible complications associated with the procedure, but should, as the post-bypass period progresses, should become comprehensive. It's quite dynamic. The hemodynamic conditions can change, and it should be repetitive. It's a tool that we have literally at our fingertips throughout the post-bypass time. We are now going to go over our proposed systematic approach for some of the surgical procedures that are presented in the document. And we're going to start with everybody's favorite, mitral valve surgery. And as we know that the severity of mitral valve functional abnormality is, be it regurgitation or stenosis, is highly influenced by the changes in the intraoperative hemodynamic conditions. So this evaluation is best performed in the awake patient under physiologic conditions through a transthoracic echocardiography. However, TEE is best suited for a detailed description of the mitral valve anatomical features. It's very important as intraoperative echocardiographer, be it anesthesiologist or cardiologist, it's very important to be aware and to know and to have actually reviewed the preoperative workup so that these can be compared with the intraoperative findings. And again, I will have to emphasize the fact that it's important to discuss and understand the planned surgical procedure. So information of interest to the surgeon starts with what is the mechanism of disease. If it's regurgitation, what type of regurgitation is it? Is it prolapse? Is it flail? Is it annular dilation? Are there clefts or commissural disease which can be diagnosed very well through intraoperative TEE and particularly through three-dimensional echo. What is the extent of the disease? Is there your typical fibroelastic deficiency with disease localized in one segment of the mitral valve, or are there multiple segments involved which may make the repair more complex? Generally, what is the general appearance of the mitral valve? Are the leaflets thickened, immobile? Are there calcifications? What is the extent of calcification in the mitral annulus? All these are prerequisites in surgical decision-making of the feasibility for repair, and if repair is feasible, for the type of repair. Beyond this, measurements regarding valve geometry and identification of failure, repair failure prone anatomy for either primary or secondary MR represent additional and often crucial information for the surgeon. Post-bypass, again, I will say it again, it's important to discuss with the surgeon and to actually know what type of procedure they have performed, as this may influence your echocardiographic findings. A quick assessment of the adequacy of repair or replacement can be done before complete separation from cardiopulmonary bypass. When the heart is somewhat loaded, you may find egregious things that have to be addressed. However, a full evaluation of the repair or of the replacement should be done after complete separation from cardiopulmonary bypass and under as physiologic as possible hemodynamic conditions and an adequate heart rate. So evaluation of residual MR, severity is important. However, also equally important is to actually find out the mechanism of residual mitral regurgitation. Diagnosing pathologic prosthetic regurgitation is important, be it intravalvular or paravalvular. And beyond that, actually localizing where that jet is originating is important. And these are a couple of examples of repair and intravalvular prosthetic regurgitation. Is there iatrogenic mitral stenosis now after a repair? And as Dr. Swaminathan has once told me, surgeons cannot fix gradients, they can fix structures. So a number is irrelevant unless it's accompanied by hemodynamic conditions, but also if there is a high gradient, is that due to a high cardiac output, or is that due to a restriction, maybe flow acceleration across the valve by color flow Doppler at the level of the annulus, maybe at the level of the leaflet tips. And obviously, complications associated with the procedure, such as maybe new aortic regurgitation. As you can see here, the non-coronary cusp has been damaged probably by a suture, and there's a small perforation, or left circumflex injury, which is obviously a complication which needs to be addressed.
So similar to the examination for mitral valve, if we all consider the advancement of percutaneous interventions for the aortic valve, I'm sure everybody has experienced more and more that the aortic valve at some point it is being repaired, and this is the cartoon that clearly matches the motion of the aortic valve cusps, similar to a Carpentier classification, so to say, for the aortic valve. Type 1 for normal motion, whereby some holes or dilatation of the annulus will be the reason for most of the time central AR, versus prolapsing cusp, any of the three or all of them, or restriction of the cusp that causes regurgitation. And again, TE will be, or the focus for these cases will be with the TE to identify these characteristics of the aortic valve cusp and whether they will be amenable to repair or not. So following that, I mean, with this in the back of the mind, since the plan can always be adjusted, it is worth to think both in cases of potential aortic valve repair as well as in cases of aortic valve replacement. Either or, it is very important to clearly, quickly evaluate the presence of aortic insufficiency, whether it is due to inadequate aortic valve repair. In the first clip here, probably the aortic valve repair looks pretty good because there is not a lot of AI. In the second clip, after aortic valve replacement, clearly you expect everything to be fine, but however you do visualize a rather significant aortic regurgitation set, and the goal there is to find out whether this is an intra-prosthetic versus a paraprosthetic leak or not. As well as, since the work is around the root of the aorta, looking for regional wall motion abnormalities because of a compromised coronary artery perfusion, as well as interventions at the root of the aorta, such as, for example, presence of or grafts or guide wires that might have caused dissection. So here in the cartoon, you see very nicely on the bottom right what we try to measure in the operating room, the depth or the extent of coaptation between the different aortic valve cusps. Measuring the gradient is always important. Sometimes the valve may be too small for the patient. And in the bottom left, the two slides clearly show a aortic proximal ascending aorta dissection and dissection flap, again in the ascending aorta long axis view. So again, it's a simple procedure. However, complications can always be lurking around, and it's all up to the intraoperative echocardiographer to focus the exam and detect such complications. Changing gears, now going to bypass surgery. Bypass is not a clear-cut indication for using intraoperative TEE. However, in the absence of other hemodynamic monitors, we can perhaps think beyond the donut view and see how else a focused TEE exam can benefit the patient care. So global LV systolic function, size of the ventricle, as well as performance stroke volume, and diastolic volume and systolic volume can give many good information regarding the size of the ventricle and the performance. Regional wall motion abnormality, of course, is what we're all been trained on from the very beginning of our TEE experiences. And the use of the biplane or orthogonal simultaneous imaging helps a lot in this case to identify examine inferior and anterior wall segments, both in short axis as well as in long axis perspective. So furthermore, TEE during a bypass case can be used for other applications. On the bottom right, you see transmitral flow. So it's not only to detect the diastolic grade that can change because of float, but here in this case, you can tell that the atrium is contracting. So in case of AV pacing, you do know that you effectively have captured the atrial activity. You can match it with a Doppler tissue imaging of the lateral segment. So we can quickly do an E over E prime and get an estimation of the mean LV filling pressures, as well as the E prime A prime ratio again along the diastolic, thinking along the diastolic function, as well as keep looking because sometimes things may, incidental findings may explain, say, an increased CVP or signs of RV failure. You need to look around and you identify a problem, RV dilatation or increased CVP. You do need to go down quickly a differential list. In this case, you can see a rare but visible example of acute PE, as well as a communication undetected between the left and the right atrium and in acutely increased volume on the right side that may explain the reason for the RV dilatation. So again, look again, and repeat your exam.
Going over to mechanical circulatory support, this is a proposed imaging strategy for patients who undergo placement of a durable left ventricular assist device. It's a sequence of views which makes more sense in terms of level of imaging and angle of the omniplane, but obviously the imaging can be done in any sequencing desired. However, all these elements of the exam should be evaluated, particularly things that may change the surgical plan. So site of anastomosis for the inflow and the outflow cannula, LV apex and ascending aorta, presence of tricuspid regurgitation. This may actually require a bicaval cannulation, or procedures that may actually now require placement of a cross clamp, such as a PFO closure or addressing the aortic valve. And while indeed these patients come to the operating room fully imaged with a transthoracic echocardiography, their preoperative course can be quite dynamic, and their condition can change quite a lot. And this is an example of a patient who had a transthoracic echo 2 days prior to presentation to the operating room. That's an explain of the left ventricle, and they even used contrast in order to rule out the presence of an LV thrombus, since this patient had such poor left ventricular function, and it was a setup for the creation of a thrombus. 2 days later, he presents to the operating room, and even if he had been heparinized, being on a intra-aortic balloon pump support, you can see that he has now developed a thrombus, and it was a large thrombus now in the left ventricle. Post cardiopulmonary bypass, after placement of a durable VAD, obviously it's important to look at the orientation of the cannulas. It's important to document velocities through these cannulas. In intraoperative 3D TEE has been used more and more in order to assess particularly the relationship of the inflow cannula with the walls of the left ventricle. But beyond that, these two metaesophageal views are highly are high yield for information, not only in terms of the results of the surgical procedure and placement of the cannulas, but more importantly, regarding hemodynamic management of these patients. Is the left ventricle adequately unloaded? Is the aortic valve opening or not? What is the position of the interventricular septum? And what is the function of the right ventricle? As these, particularly these patients can have quite a rocky and dynamic, sometimes unstable post-bypass time. So again, in dynamic conditions, a repetitive exam is very important in these patients. We are highlighting the Impella as the representative for a family of percutaneous devices that can be used for the partial support of both the left ventricle and the right ventricle. Pre-placement of the temporary this temporary microaxial device, pre-placement specific findings that can actually preclude the placement of the system and are contraindications. Some of them contraindications to the placement of an Impella can be the presence of a prosthetic aortic valve, especially a mechanical prosthetic aortic valve, the presence of a heavily calcified and stenosed aortic valve, any type of subaortic stenosis, be it a very narrow left ventricular outflow tract due to hypertrophic cardiomyopathy or any type of subaortic membrane, the presence of a redundant myxomatous mitral valve, which may obstruct the inlet of the device. During placement, these devices are placed under both fluoroscopic and echocardiographic guidance. You can actually look at the guide wire, make sure that it's actually aiming for the left ventricle and it's not getting entangled under the mitral valve in the subvalvular apparatus, disrupting the subvalvular apparatus and maybe leading to worsen mitral regurgitation. You can appreciate the curvature of the device with the tip again pointing towards the LV apex, making sure that it's at an adequate depth in the left ventricular cavity with the outlet above, well above the aortic valve. And post-removal, you can actually evaluate not only left ventricular function, but more importantly, is there any damage done to the cardiac structure? Is the aortic regurgitation, is there new or worsened aortic regurgitation? Is there new or worsened mitral regurgitation? And this is an example from a patient who underwent removal of the device. And you can see that there is a perforation of the anterior leaflet. You can see it here in 2D, here with color flow Doppler. And here in 3D, this is a surgeon's view with the aortic valve on top. The mitral valve is here, and there's a perforation through what seems to be A3 or almost close to the posterior commissure, which was likely, which the patient likely incurred during placement of the device.
In the document, you will see the sections about transplantation, heart, as well as lung. And here a couple of examples how focused TEE can aid managing a patient undergoing lung transplantation. Obviously, those who are taking care of this patient realize how complex and busy the time is handling both hemodynamics, respiratory physiology, and echo. So suffice to say that the focus in lung transplantation is the function of the right ventricle, so tricuspid regurgitation, pulmonary artery acceleration time as an index or a correlate of RV systolic function, as well as very critically the pulmonary vein flow profile, baseline velocities, as well as their phasic pattern. Obviously, again, it will be affected by the VQ ratio and the order that transplantation happens. Here it's a graphic example of a restricted anastomosis or a kinked or a narrowing. No matter what it is, again, we talk about gradients, and you can see the acceleration with color, as well as the high velocity with a continuous wave Doppler, full envelope, and lack of phasic pattern. It's enough to bring this to the attention of the surgeon, and that will be enough to alert them and have them go back, relieve the anastomosis, revision or unkinking, and you can see clearly the change in the pulmonary vein flow velocities, how clearly the velocity, peak velocity has decreased, and the phasic pattern, systolic and diastolic, appears again. So rather graphic example of a very critical contribution of the TE that is based on the exam being focused and repetitive, knowing what the surgical steps are and where that's where you should be focusing the exam. And again, revisiting the same with the same imaging again and again until you have an effective resolution.
For heart transplantation, there are multiple roles for intraoperative TEE. Pre-transplant TEE is used mostly for intraoperative hemodynamic management. However, the sites of future anastomosis should be surveyed, and it is important to rule out the presence of thrombus in the heart, as the heart is being manipulated quite a bit in the pre-bypass time, and that can lead to dislodgement of the thrombus and embolization. After transplant, the exam is, as Nick mentioned previously, somewhat focused. It's important to quickly evaluate all the anastomosis sites, make sure that there's nothing egregiously wrong with them that may require immediate return to bypass, IVC anastomosis, SVC anastomosis, as well as the pulmonary artery anastomosis. The graft, the function of the graft, both right ventricle and left ventricle, has to be evaluated. And this evaluation has to be repeated several times post-bypass, especially at times of hemodynamic instability, as graft dysfunction can happen at any time in the post-bypass time. And then the exam has to progress quickly to a comprehensive evaluation of the newly implanted heart with a complete valvular exam. So talking a little bit about the heart team, the concept of heart team in the operating room, it's very important to communicate clearly with the surgical team, and actually to speak somewhat a common language. So discussing the surgical procedure, it is important for us as echocardiographers to have an informed understanding of the technical steps of the surgical procedure, and discuss and understand on how our new echocardiographic findings may affect actually the surgical plan. I do understand that many of us actually work in a private practice environment where they may be the sole provider. I have heard of other mentioning the rush to heparin pre-bypass. However, as we have undergone so many cultural changes, maybe we require one more cultural change. Do we really provide a good service to the patient by rushing pre-bypass to go on pump, or should we indeed take our time to perform as comprehensive an exam as possible? Do we actually need an echo timeout, for example, where we provide a surgeon a full interpretation of our findings? It is important to utilize a catch-all protocol. this will allow you to, even if you are focused at the beginning of your exam because you're trying to answer questions that the surgeon might have, which may affect the surgical plan. However, by using a catch-all protocol, you can ensure the fact that you routinely perform a similar exam in a way that you look at all the structures and that you don't miss findings because of that. So having a routine of using an imaging protocol over and over again is very important. The intraoperative echocardiographer should be part of a preoperative planning, and there are multidisciplinary conferences out there in all the institutions that discuss patients who come for cardiac surgery. So one more thing to keep in mind. And also, while we unfortunately do not give you, this document does not give you the answer to the hard questions in terms of should we or shouldn't we go back on pump for that paravalvular leak. We hope that it provides a guide to actually acquiring the necessary information, the necessary echo elements that can help together with hemodynamic data and patient factors, hopefully in answering those difficult questions, as these decisions are complex. So we would like to, if you haven't done it yet, we would like you to encourage to read that document, give us feedback, and be on the lookout for a library of case studies which will accompany the different sections in the document and will be available for free on the ASE website. So with this, we would like to thank you for your attention. Hopefully we have answered some of your questions. Hopefully we have raised some questions, and we look forward to hearing from you.
So there was I will wait for Liz to tell us whether any questions are waiting in line, but there was a question that I quickly typed, but I will throw the curveball to Alina and repeat the question for the benefit of everybody who's on the webinar. What is the best technique or method to quickly evaluate the severity of MR intraoperatively? That was the question that I answered by typing, but I will ask Alina as well.
So we are talking about mitral regurgitation pre-bypass, or we are talking about mitral regurgitation post?
It was not specified there. The question was only how to best detect intraoperatively the severity of MR. So that's the question.
Well, there is no, it depends. That's the best answer. Well, I think it's a complex answer, as MR is a complex valvular lesion. And obviously you have to use whatever you can. Obviously color flow Doppler is the cornerstone for evaluation of any regurgitant lesion. So I would start with that, keeping in mind that color flow Doppler depends on various, or has various limitations, and that includes momentum. So what is your left ventricular systolic pressure or your systemic pressure? What type of MR is it? Is it constrained by left atrial walls or not? What are your color flow Doppler settings in terms of velocity map or gain? So all those can influence the appearance of mitral regurgitation by color flow Doppler. Beyond that, I think I would rely on also on, let's say, the so-called softer parameters for mitral regurgitation. in terms of is there left atrial dilation? Is there on my transmitral flow, is there a prominent E wave with a high velocity, which could be an inkling to the fact that the left atrial pressure may be elevated. You could use pulmonary vein flow if there is or there isn't a systolic blunting on your pulmonary vein flow. That could be an added clue into the presence of elevated left atrial pressure. And then obviously, if time permits, you could get into a more functional evaluation of the regurgitant volume, although this is riddled with all kinds of traps in terms of PISA evaluation and, timing in the cardiac cycle and all that. That's, thoroughly covered in the native valvular regurgitation guidelines.
So, Alina, while you were answering this, I was tapped into the 4 open questions right now. So you can look at them yourself, but to give you a break, I will take one and then pass the next one to you. There is a nice, good one about policies in the air that we should perhaps address with everybody. So I will answer the question about what is your routine exam views and steps you look at for CABITs to do the exam efficiently and comprehensively. So similar to the degree of MR, there is no clear-cut solution or recipe. Everybody will find what suits his or her practice. But since you have asked the question, I will tell you that if I'm running out of time, I always start with the mid-esophageal LV long axis view, because I can look for transmitral flow. I can quickly go to the bicaval view to look for pulmonary vein flow that Alina just mentioned. I can do a 3D zoom around the aortic valve to see for AI, stenosis, motion of the cusps, get the LVOT diameter for LVOT stroke volume. And my next view is always the short axis view, transgastric mid-short axis, because of regional wall motion abnormality. Again, this is a personal preference. Others will follow a different roadmap. The document is bringing together different imaging views, and everybody should create their own roadmap. So since Alina was answering very well the severity of MR intraoperatively, the question was, in the preoperative TEE, what is the best way to assess / predict post-SAM after mitral valve repair? And if you don't mind, you can take the first shot at it before I help you.
Yeah, so again, this is not a simple answer, because there are many elements that you have to take into account. Yes, there is the measurement of the CSEPT, which everybody loves and likes, but there are several studies out there which have actually looked at the timing of this measurement or the cutoff of this measurement, and they're actually quite varied. The cutoff can vary anywhere from 1.5 to 2.5. And actually, in my discussions with Dr. Maslow, who's the first one who came with these echocardiographic measurements for the prediction of SAM, he actually said that the CSEP measurement was not the strongest predictor of SAM, was actually the ratio between the lengths of anterior leaflet, posterior leaflet, that is from the annulus to coaptation, not taking into account the coaptation length. So I think one has to take into account all these elements: CSEPT, ratio of the anterior to posterior leaflet, how small or big is the left ventricle, is there hypertrophy of the interventricular septum, how long is the leaflet, how long are the leaflets, both anterior and posterior. So all these elements would play a role into the prediction of SAM. But ultimately, you have to discuss with your surgeon what type of repair are they planning to do, and combine all this information into the prediction of postoperative SAM.
You know,
Hopefully this answers your question.
as Alina pointed out, if the surgeon will be implanting neocords, that will guide the anterior leaflet away from the LVOT. So probably you will not be seeing SAM, but in that case, you will be on the lookout for iatrogenic mitral stenosis. So again, the point is to communicate, knowing what they will be doing on the other side to be able to accordingly answer this type of questions. There is a question about what is the best approach to grade the RV dysfunction or the severity of AI after LVAD. I would take the first shot here. For me, it's always the 4-chamber view because it shows you the position of the IV intraventricular interatrial septum to show whether the RV is about to fail. And for AI is usually, again, a long axis view to see whether the valves, the cusps are opening and the degree of aortic insufficiency new or persisting or worsening. Alina, you summarized the communal thinking of, or the conclusion of the document that hopefully we should be, and we are, members of an echo heart team. And again, the point of the guidelines is to be focused, repetitive, to always communicate actionable information to the surgeon. So one of the viewers posed the question, wouldn't it be useful if such guidelines, our guidelines, included a clear statement about the need of a proper perioperative service team with dedicated cardiologists and anesthetists? Too frequently, hospitals strive for a cheap fix. That needs some editorial comment, Alina.
Yes, indeed it does. And it actually, the question, I don't know where the person who asked the question is from, but the timing of the question is good because it comes at a time when I think the issue of the perioperative service will become more and more a topic of discussion for hospital administrations. I have been part through the Intersocietal Accreditation Commission as the ASE representative. I have been part of the group that has put together a document which addresses guidelines and standards for the setup of a perioperative service in terms of everything: equipment, exam storage, reporting, elements that a perioperative service should do. It's a good document which could be used as a roadmap and in a way as leverage for those who want to set up a perioperative echocardiographic service in a practice that has cardiac surgery. It is a little bit unconscionable that, you know, a practice that has a cardiac surgery practice that does this kind of procedures does not have a perioperative service in terms of, you know, all the elements that are required for proper functioning. All these are hard questions. But you deal more with the hospital administration than I do, Nick. So maybe you have some more insight into this.
No, it was Dr. Serino from UK who posted the question. And again, it varies from place to place. Where I am, it's a bundle payment. So anybody can do as many echoes as possible. In a place where echoes are being charged or had to be scheduled on a patient's record, and they are charged to the patient's insurance, you may be limited in establishing such a practice and how much equipment you may be able to use or not. So it's, I think it's regional. It makes a lot of sense, but I think we'll be getting there the same way that the valve heart team was accepted for the percutaneous interventions. Our presence via collaborations, research, and publications will make this, the utility of such a team be more easily accepted, and that can affect the change.
Yeah, unfortunately, it's difficult to actually show in terms of outcome the value of intraoperative echocardiography. There are some studies out there for sure. One of them actually coming from Cleveland Clinic, you know, almost 2 decades ago, which showed that intraoperative TEE in mitral valve repair makes a difference in terms of the durability of repair. But I think more work has to be done in this regard in order to have a full complement of.
It's a regional practice. You mentioned there are institutions even in the United States where only cardiologists do echo in the operating room, while the anesthesiologist is not. So you realize from Dr. Serino's experience where there are no cardiologists doing perioperative echo, there are places that anesthesiologists are not doing perioperative echo. So it is, again, needs to be addressed at the local level. I think we reached the point that TEE is considered as good as a pulse oximeter. It's very difficult to do, to prove the efficiency or not. We know it so well. I don't think we can give it up.
All right, well, unfortunately, we are out of time for today. For any questions not answered here today, a Q&A handout will be made available when the Enduring webinar is posted. We would like to thank everyone for participating in today's webinar, and a very special thanks to Dr. Nicoara and Dr. Skubas for presenting on behalf of ASE. As a reminder, please log into your ASE Learning Hub account to claim CME credit. Detailed instructions will be emailed to you shortly. Be sure to visit ASE Learning Hub for future live webinars. I hope everyone has a great evening.